Welcome back. Now we're going to talk about manual muscle testing and everything what we need to know about it. Again, we're gonna practice this when I see you on campus, but this is just a bit of information which I would like you to know. It's just very important to understand when the manual muscle testing comes from and what does it represent. So of course, manual muscle testing, it's a tool to measure strength. The question is, what is strength? Well, strength would be a maximum capacity of a muscle, any given muscle, to contract once. That's the strength. That's the difference between strength and endurance. Endurance is to repeatedly perform certain movement. Strength is one-time deal. How much? How much can I lift in one shot? That's a strength. And that's what we want from the manual muscle testing. So why do we use it? Similarly to goniometry, or you can say identical to goniometry. Everything what we said in the previous video about goniometry, it actually applied to manual muscle testing for the same reason. We want to know how strong the patient is right now. We want to know how strong the patient was before, in order to get the patient to the point when before the injury or the incident, accident, a sickness happen, so the patient can be as independent with ADLs, IADLs, leisures, and you name it, as possible. And as possible for this particular patient. Okay, so let's go to slide number 2. Subject factors: general health, pathology, gender, age, activity level, occupation. Very similarly to range of motion. So I can just add to that list that I like to also talk about understanding diagnosis. As OTRs, we cannot diagnose anybody. We just simply can't. It doesn't belong to our profession. However, I can share with you, I get this in that situation perhaps 3 or 4 times in my entire career, but it happened. So it maybe happened to you already, or it may happen to you in the future. But before the evaluation, of course, the first thing what you need to do is open the patient chart and familiarize yourself with the chart before you even say hello to the patient. So I opened the chart and there was a diagnosis, and I'm going to read it for you. I wrote myself a note to remember exactly verbatim how the note went, how that was inputted in the patient chart. CPT code 799.3. Mortality and morbidity due to disability, unspecified. If you understand this, kudos to you, because I swear I could not. I had no idea what that means. Morbidity and mortality due to disability, unspecified. What am I seeing this patient for? So fortunately, my patient was able to tell me that she simply lost consciousness for a couple of seconds. She fell and she broke her hip. So basically, this diagnosis was completely misleading. I couldn't understand it. Before I went to see the patient, I actually called that doctor. Of course, the machine picked up the telephone call. I left a message. Nobody ever called me back. But my point is that the more you understand about the diagnosis, the more you understand about the problems and different issues related to your particular patients, the better you will serve them as an OTR. The better for you, the better for profession. So it's very important that we keep that in mind. So like I said, it helps to understand the diagnosis to understand what happened to the patient. So the more you know, of course, the better. All right, so the other things like general health status, of course, pathology, we talked about that already, gender as well. Again, are all men stronger than women? I don't think so, right? Let's take like a bodybuilder or karate woman or you name it, some sport athlete, and a man who is just simply a couch potato. Who would win? Who is stronger? All my money goes on the woman, right? But stereotypically speaking, men should be stronger, physically stronger than women, for very simple biological reasons. Men have more muscles, more muscle mass. We are composed of less water, more muscle, as compared to a woman. Now, of course, this is stereotypically speaking. You can always find somebody who is different, and that's okay. But again, this is a good stereotype, not a bad stereotype, because majority of people are really biologically are built this way. Okay, same thing with age, and of course activity level and occupation. But I don't think that requires any more explanation. All right, let's go to the next slide. Factors affecting muscle strength, psychological, social factors. Psychosocial factors. Motivation is huge, and you know this already because you're working with your patients. If the patient doesn't have motivation, the patient is not going to do anything. Period. So motivation heals. Or at least aids in healing process. Cognition, very important. There is cognition and motivation actually do go together. If somebody understands and is cognitively intact, this person might have a better motivation. Not that it will 100% of the time, I'm just saying chances are. Distress and anxiety. Depression is huge. If somebody is depressed, the motivation automatically goes to drain. I remember I had a patient, I came to the room and he was very verbally abusive towards me, and not only towards me, towards anybody who entered his room. He was perhaps in his mid-50s when he shouted at the top of his lungs, "Leave me alone, people, you don't understand that I want to be left alone. I want to die." And I went to the medical chart, I checked his cognitive status, already recorded by other professionals in the medical chart. Turned out that without cardiac surgery, without open heart surgery, the doctor told him he will die. He must have that surgery in order to survive. This gentleman was not interested in living. He refused therapy. He refused surgery. We had to discharge him. He went home, and my understanding is that he did die later on. Fear of injury, and of course self-efficacy. Self-efficacy is huge. And for those of you who are working with particularly with adults and geriatric population, although in pediatric population I am sure you can find examples of the self-efficacy as well. Some people do not want to do certain things for themselves, and I have a perfect example of a Hispanic gentleman. And why I'm saying Hispanic, because it's cultural, right? So it's a South American gentleman, don't remember exactly from what country, but he refused to tie his shoes, and he couldn't bend far. So I asked him, would you like to work to bend farther and tie your own shoes? His answer was, believe it or not, no. And I was like, why? It's like, well, my wife is doing this for me for the past 5 years, and she's doing fine job. I don't see any reason to change it. Well, I could not possibly change his mind. So I asked him, would you like to work on putting on your pants? Oh yeah, he liked that idea. So there we go. So of course the patient wishes must be respected by us, and that was fine. You don't want to put your shoes on, you don't want to tie them up because your wife does this for you and she's okay with that, that's fine. But if you want to put your pants on, we have to work on those skills one way or the other. So self-efficacy is very, very important. And that, of course, goes with everything else, right? With motivation and depression and distress, anxieties. Everything is connected, like in the human body. Okay, factors affecting muscle fibers. All right, so we have a few of those. So let's go one at a time. I'm gonna look at my screen, so I'm seeing what you are seeing, and we're gonna discuss this. So muscle factors, type of fibers. Well, we have, generally speaking, two types of fibers. We have red and white muscle fibers. Red are known as a slow twitch muscle, okay, or slow muscle. When the white are going to be the opposite. They're going to be a fast twitch muscle, or simply fast muscle to react. Why red and why white? Well, they appear to be reddish or whitish in real world, in appearance. Why? Because the redness comes from mitochondria and myoglobin. So they do really appear red. When the white have less mitochondria and myoglobin, therefore they appear to be more pale. What else I would like you to know? Red muscle fibers are smaller than white and they aerobic. White fibers are larger and anaerobic. Okay, let's explain this a little bit, what that means, large and small. Everybody understands that, but aerobic and anaerobic perhaps need some more explanation. Aerobic, the ones which are required by red muscle fibers, needs oxygen. Without breathing, without supply of aerobic, they are fatiguing very fast, very quickly. You can't use them. The white fibers are larger and they are anaerobic. That means that they utilize the stored energy in our body. The ATP. ATP is a stored energy in our body. Okay, now, do we have muscles which are completely red or completely white? No, absolutely not. Every muscle consists of both types, red and white. Okay, but you can literally change the composition of your muscles by training, by occupation. So, for example, muscle rich in white fibers are built for fast reactions. Speed, jumping, running, throwing, sprint. So you bet that the sprinter looks different than marathon runner. If you don't believe me, look at the Olympics. Sprinters look almost like bodybuilders, when marathon runners look like average Joe. You can't even see that muscles are so well trained because they train themselves to change the composition of their own muscles. So muscle rich in red fibers are built more for stability and endurance. So my question is, if you're standing for prolonged period of time in one spot, which muscle fibers are you using the most, or which muscles are you using the most? Well, the muscles which are richer in red fibers as opposed to white fibers. I hope that I explained this fairly well. Okay, the next one is intervention ratio. A little bit complicated, so let me explain this, okay? What is intervention ratio? Well, let's just take a look at this name itself. Ratio meaning some ratio from one number to the other. Ratio of two different things, right? How many, let's say at college, it's 1 of me, 24 of you. The ratio is 1 to 24, right? The smaller the classes usually tend to be considered better classes, because it's one teacher per, let's say, 10 students, right? Or you can have huge classrooms, 1 to 100. I remember when I was taking a anatomy class at FIU, was about 140 students in one huge auditorium and one teacher. So the ratio was 1 to 140, right? So that's what we're talking about, but we're talking about the muscle fiber intervention. So let's take a look at that. So this is an average number of muscle fiber per motor unit in a given muscle. So I just gave you a very dry definition. So let's take this apart, okay? First and foremost, I said this is an average number of muscle fibers per motor unit in a given muscle. So the question is, what is motor unit, right? What is motor unit? Well, alpha motor neuron and all muscle fibers which are innervated by that alpha motor neuron, it's considered a unit. Okay, so one more time. Alpha motor neuron, every motor neurons are actually called alpha. So alpha motor neuron runs from your spine and attaches to multiple muscle fibers on the other end. This one axon of the motor neuron attached to the number of muscle fibers, this would be considered a motor unit, one motor unit. Now each muscle have many motor units in order for the entire muscle to contract or release and relax. Okay? So the question is, the bigger muscle are working and are expected to different work than the small muscles. So which muscles would benefit from the larger intervention ratio? Which muscle would benefit from the smaller intervention ratio? Okay, this is important concept to understand, because if I want to do fine motor skills, like something to that effect, I'm moving my fingers like that, I want to hold my pen in this fashion, this requires a lot of fine motor movement, meaning a lot of muscles are involved in this particular hold, and those muscles have to be very, very specific. Therefore, the intervention ratio is smaller, and I'm going to explain it to you in a second. How does this work? Because it's almost counterintuitive, isn't it? Okay, large muscles like my quadriceps or hamstrings do different type of work. I don't need to be that specific. They do not have to do fine motor skills like my fingers. They just jump or walk, or I can sprint because I have those muscles. It's a gross motion as opposed to fine motion. So the gross motion, the big muscles, actually requiring a larger intervention ratio. Okay, how to understand those intervention ratio? Let's take into consideration a ship, a cruise ship. Which cruise ship would you as a passenger enjoy better? with a lot of staff or very few staff members on the ship? Certainly you would enjoy a lot of employees as a ratio to the number of passengers. The more employees, the less passengers, the better quality service you have. This is a lot of workers, not so many cruise goers. So what's happening over here? Smaller intervention ratio. The numbers are closer to each other. When big muscles don't need that. They don't need that fine motor skills. They just grossly okay if you give them less input. So less workers on that ship are serving more cruise goers or more clients. So the intervention ratio is greater. It's a big difference between number of workers or employees of that particular ship and the number of cruise goers. Okay, so I hope that that was clear enough. Okay, fiber architecture. Fiber architecture, we're going to talk about it in the next slide. So I'm going to omit that for a second. The next one is type of contractions. Well, we have primarily two different type of muscle contractions. Is isotonic and isometric. Isometric simply means you do not see the movement. Muscle contract, but you do not see the movement. Let's say I'm holding bottle with water and I'm holding it. I'm not moving. I'm not going anywhere with that bottle. What does this mean? Well, it's an isometric contraction of my muscles. My muscles worked, but the bottle didn't go anywhere. And the second type is isotonic. Now, isotonic divides into two: eccentric and concentric. The eccentric or eccentric is when I'm holding the bottle. Let me find the right angle right here, and I am going to put that bottle down. Now my biceps is elongating when my triceps is contracting. Now the other way, my bicep is contracting when my triceps is elongating. So remember, you have always two sets of muscles. One contradicts the other. So one is doing concentric when the other is doing eccentric, the opposite. So talking only about the biceps, let me find the right angle. I'm concentrating the muscle or I'm elongating the muscle. So concentric movement, eccentric movement. Okay. The next one is type of contraction. We just talked about that, number of joint crossed. This is very important to understand, and you have to know your anatomy. You have to know where the muscle originates and ends and inserts, because the strongest muscles are crossing only one joint. The more joint muscle crosses, the weaker it becomes. And you have to lax or relax the distal part of the muscle in order to really focus and measure the strength of the muscle which is more proximal to the body. And we have many examples, but as we go with the program, we will talk about those muscles much more extensively. And of course, when we see each other face to face, I will explain this one more time during our meeting. But remember, this is the point to take home. The less joints crossed, the stronger the muscle. The more joints crossed, that weakens that muscle. Vascularity is very important. Older people have difficulties. Older people are weaker for many reasons, but one of that is that they are drier. The vascularity is not the same. So keep yourself well hydrated to avoid those problems in the future. Keep yourself always well hydrated. It will pay off later on in life. And of course, the fatigue is a sudden decline of muscle strength for different reasons. Okay, let's go to the next slide. This is the one which I said is about fiber architecture, and you have several different types of muscles. The way and what I mean by types of muscles in this case is the way the fibers interact with each other and create the bulk of the muscle. There is several different types, but generally speaking, if you will, to put them in only two groups to simplify that, we can talk about pennate muscle and fusiform muscles. Okay, so pennate can be unipennate, bipennate, or multipennate. On the picture on your slide, you can clearly see bipennate, right? Because you can see on the left hand side and on the right hand side you can see those fibers going and attached to the tendon of the muscle. Fusiform it's in this case, in this particular picture, they are parallel. The fibers goes parallel to each other. We have both type of muscles all over our body, and of course certain muscles are unipennate, meaning they have only one side of those angulated fibers. You got a bipennate, which you can see on the screen or on your PowerPoint, and you have multipennate, which consists of more than just two of those feathery looking structures. Now let's talk about strength of this muscle. Which muscle is stronger, generally speaking, the pennate and the fusiform? Well, I can't tell you that without a deeper understanding of that structure of that muscle itself. So let's talk about it. Let's take into consideration fusiform first. So if you take couple of fibers from fusiform muscle and a couple of fibers from pennate muscle and you compare the individual strength, the fusiform muscle is stronger, simply because it's pulling directly from one side to the other. When pennate muscle attaches in angular way to the muscle tendon and must perform different type of work in order for the muscle to contract. So basically speaking, fusiform muscle fibers are stronger than pennate muscle fibers. But there is a trick. What that means, if you take a relatively similar size of muscles, or in other words, muscles with the same number of fibers, I take that back, not the same number of fibers, but the same size. The pennate muscle can pack more fibers per square inch than fusiform, simply because of the arrangement or architecture of that muscle. So if you calculate this mathematically, pennate muscle is stronger than fusiform muscle simply because it packs more fibers per square inch than fusiform. One more time, I know it's a little bit confusing. If you take individual muscle fibers, fusiform formation or the way the fibers are aligned would give you more strength than individual fibers of the pennate muscle. If you take the entire muscle into consideration, which is about the same size, pennate muscle would be stronger simply because it packs more fibers into the same area. How much stronger? Well, the average inclination of those fibers in pennate muscle is about 30 degrees. So taking into consideration the number of fibers and the 30 degrees inclination, let's say pennate muscle can perform 100% of certain motion or contraction. Fusiform loses that strength because of the fibers architecture and gives you only 86% of strength. So let's say for similar size muscle, pennate muscle can contract as much as 100 pounds. Same size fusiform would contract only with 86 pounds. Does this make sense? 86% to 100%. Fusiform weaker than pennate muscle. Fusiform individual fibers stronger than pennate. Okay, I hope everybody got that. Let's go to the next slide. Okay, ways to assess muscle strength. Different ways. Screening. We talked about screening already. Tools exist that give a general estimation. Nothing else, just observation. Can you do this? Can you do that? Functional motion testing. This is a very popular way of assessing somebody's strength, but it's not a formal evaluation. Functional motion testing is primarily for goals related to activities such as ADLs, IDLs. Can the patient brush her teeth or not? Can the patient dress herself, etc. Those are functional motion testing. Manual muscle testing is different because it's a well-established protocol which we have to follow, and only manual muscle testing gives you the numbers, which we are going to talk about those numbers in a couple of slides. Why do we have take measurements? The same as with the range of motion, to establish baseline, set goals, plan our treatment, to discern how muscle weakness interferes with ADLs or anything else, IADLs, etc., etc. To assist with diagnosis, again, we do not diagnose people, but we can assist, or the information, the knowledge can assist us to understand the diagnosis. To prevent deformities, to objectively measure amount or lack of progress. The same with goniometry. It actually gives us numbers. The number comes with the description. So we have an understanding of where the patient is and where we want this patient to be. To aid in activity selection, establish needs for adaptive equipment again. Again, research the effectiveness of therapeutic techniques. You are implementing certain techniques. Are they working or not? Screen for job placement and return to work, possibly, not for everybody, but there are certain population and special settings when you're actually working with this type of population. And medical and legal reasons. Remember that everything what is written down and signed and dated, it becomes a legal document which can and will be used in court, depending on needs, of course. So when do we take measurements? Similarly with range of motion, initial evaluations, re-evaluations, and discharges. So far, you as a COTAS were able to do those measurements during re-evaluations, or perhaps every other day, depending on the patient needs, for you to understand if you're reaching the goals or not. But official documentation always had to be signed by OTR. Well, when you graduate, that's gonna be your job. Limitation of manual muscle testing comes with limitations, of course. Cannot measure the muscle endurance, again, because we are only focusing on one-time deal. Can you do this one time? And I'm gonna measure it, and I'm gonna tell you the number. We are not measuring endurance, and this is not a test to address endurance. Muscle coordination, the fact that somebody is strong doesn't mean that somebody is going to be able to perform activities, writing or ADLs. Motor performance, and cannot perform if the brain is not intact, if some deficits are with the brain or central nervous system, generally speaking. So again, this is the limitation of the entire biomechanical frame of reference, and it also comes to place when we're talking about range of motion, as well as when we're talking about the manual muscle testing. Okay, muscle grading. All right. All of this information is in Pedretti book, so I encourage you to open the Pedretti book and learn this, and learn it well. You have to know it like the back of your hand. I promise you, you will, or can't pass my course. Okay, so let's talk about that. I like to always start with FAIR. Why? Because it's the simplest to start with, and then we can work our way up and then work our way down. I strongly encourage you to open the Pedretti book. It's right there, but I will do it right now, right here. So just maybe I will clarify something which you might not get from the book. All of those either descriptive or letter or number are interchangeably used, so your responsibility is to get used to all three forms. Okay, so let's start with FAIR or F or 3. What does this mean? Well, that means that the patient can do full range of motion against gravity and no resistance added. So for example, I can do shoulder flexion all the way up. This is against gravity? Yes, it is, because it's perpendicular to the floor. Everything what is perpendicular to the floor, we're gonna call it against gravity. Everything what is parallel with the floor, well, there are different names for it. Gravity lessened, gravity eliminated, or I simply can refer to it as a no gravity for easiness of conveying the information. Against gravity, no gravity, perpendicular to the floor, parallel with the floor, or horizontal. Okay, vertical, horizontal. You can understand this way. So FAIR, full range of motion against gravity, no resistance added. Let's go up. There is an F or FAIR plus or 3 plus. So we added that plus. What that plus means? Well, we cannot take away anything, so we are with full range of motion against gravity. But remember, was no resistance added. So now we can add what we call minimum resistance. So full range of motion against gravity against minimum resistance. That brings us up to good or 4. Well, what can we add? We can add more resistance. We had minimum resistance, so now we can add more resistance. We're gonna call it moderate resistance. So full range of motion against gravity against moderate resistance. What else can we go? We can go as much as normal or 5. The scale is up to 5, from 0 to 5. So it's 5 over 5, if you will. You can even add that slash over 5, because that tells you clearly that the scale it goes only to 5. So normal is full range of motion against gravity against maximum resistance. Now, what is maximum? What is moderate? And what is minimum? It's really up to your professional judgment and the clear holistic picture of your patient. What is normal? for a young girl is not what should be normal or expected from a middle-aged man. What is expected from the middle-aged man, it's not what expected for 85-year-old woman. So you have to take into consideration the big picture. You have to take into consideration the individual patient and consider what's normal for this patient, what's normal for this population. It's a semi-subjective, but it is based on your experience and your professional knowledge. Okay, so we started with F, with fair, or with 3/5, because it was easier, right? For range of motion against gravity, no resistance added. Then we climb our way all the way till normal, or 5/5. So let's go lower. When we had fair, we stop at fair, full range of motion against gravity, no resistance added. What can we take away? Well, we didn't have resistance already, so we can't take resistance away. We're not gonna take gravity away yet. So the only thing what we can take away is range of motion. So fair minus, and I'm going to give you like a semi-definition, what I remember from the top of my head, but you can check me against the Pedretti book. It's less than half of available range of motion against gravity. And of course we didn't have any resistance already, so you can just add no resistance. So it's less than half of available range of motion against gravity, no resistance added. Okay, so if you don't know what's normal range of motion, you would never know what's more than half or less than half. Okay, so this is more than half but less than normal, because if it's normal, it would be 3, so it has to be less than normal but more than half. So let's say, for argument's sake, that normal for your patient's shoulder flexion is from 0 to 1/6, and I said 1/6 because it's easy to divide. 1/6 divided by half, by 2, is 80. So if the patient would perform only up to 110 and gets very weak and drops, very weak, that's 3 minus. Why? Because it's more than 80 but less than 160. Make sense? Okay, let's go to poor plus, or P plus, or 2 plus over 5. Well, this is the most complicated one, and thankfully only one. Why is complicated? Because it changes. You can do this against gravity, you can do this without gravity. All right, let's talk about with gravity first. So, less than half of available range of motion, or normal range of motion for that person, less than half against gravity, and of course no resistance added. So again, if the patient was 160 for shoulder flexion, we know that the half would be 80, but the patient can do only 45. Less than half? Yes, less than half. Visible movement? Yes, visible movement. Against gravity? Yes, against gravity. Therefore, less than half of available range of motion against gravity, no resistance added. And that makes sense. It kind of follow the formula we use throughout the manual muscle testing so far. But, and again, this is only 2 plus, this is only poor plus, could be measured without gravity. So we're gonna take gravity away, or we're gonna minimize the gravity, or lessen the gravity, depending on the terminology you want to use. How can we do that? How can we eliminate gravity? Or how can we make that gravity less? Well, fairly easy actually, by changing the position of the patient from movement, perpendicular movement to horizontal movement. We're changing the position of the patient. How are we going to do it? Well, it's almost impossible for me to present in this form. I will show it to you when we see each other on campus, week 2. And then you are going to show me during practicals, week 6. So learn it and learn it well. So again, what 2 plus over 5 means without gravity? We're getting rid of gravity, so we have to gain something. So the definition is full range of motion, no gravity with minimum resistance. Wow, that's completely different than against gravity. Okay? All right, let's go now to poor. What can we take away? What is the easiest to take away? Yes, you guessed it correctly. It's resistance. So what we are left with? Full range of motion, no gravity, no resistance. That's 2 over 5. That's poor. Well, what's poor minus then? Well, let's think for a second. What can we take away? We took already strength. We took already gravity, but we left with full range of motion. Let's take away some. This time we are not like in fair minus and poor plus. We do not have to divide the motion in half. This time it's simpler. Simply less than full range of motion, but visible. Must be visible range of motion, but less than full, no gravity, and of course no resistance added. That's a poor minus, or 2 minus over 5. Trace. What is trace? Pay attention that I always mention visible movement. It is important piece, because trace is just a twitch of a muscle without that usefulness or actual partial range of motion. It's just a twitch of a muscle, just a twitch of the muscle and no useful movement whatsoever. That's gonna be trace, or 1 over 5. And 0 or 0 over 5, it's flaccid, when there is no movement, no muscle contraction, and you can't even palpate the muscle being contracted. That's 0. Okay, I hope I did pretty good job with explanation. Read Pedretti book. There is the same information or very similar information. If you have any questions, and practice on each other. Practice on each other. If you have any questions, let me know. And I do believe that this was the last of the slide. So I hope you learn a lot, and I see you next time. Thank you.